So, what I'm saying here is that pharmacokinetics are important if the consequences of under and overdosing are severe, and the likelihood of under or overdosing is significant. And really, that applies to most of the drugs that we use to treat cancer. Not only that, but the pathological states that are likely to be important are also common in patients with cancer. So pharmacokinetics is important to patients with cancer. Some examples. Cyclosporin. Cyclosporin A is a drug that we use as an immunosuppressant, and it's principally used in transplant patients for cardiac transplants, but bone marrow transplants also. It's a cyclic polypeptide. It's highly lipophilic. It binds to the enhancer region of IL-2, and it reduces transcription of various cytokines, including IL-2 and interferon gamma and other interleukins. And it acts on T helper cells. It's used in all transplants, and it has very variable pharmacokinetics. Here's an example from patients who have received renal transplants. This was a study from a while ago, but a very detailed study. And what they found was that if you looked at the pharmacokinetics of cyclosporin in these patients, there were various factors which predicted that a graft would not survive. And the things that were important to her, if the bioavailability, which is abbreviated to F, fairly standard abbreviation, if you have a low bioavailability to less than 25%, your graft was more likely not to survive for a whole year. You'd get rejection. If your clearance of cyclosporin was high, you're more likely to get graft rejection. If your oral clearance, so the apparent clearance after an oral dose, was very high, likewise. Similarly, if you measured steady state concentrations or average concentrations or concentrations of cyclosporin 24 hours after a given dose, if those were low, you were more likely to have a rejected kidney after a year. And here's one example. So here we have the average concentration of cyclosporin over a prolonged period of time and graft survival, and you find that if you have a concentration which is less than 400 nanograms per mil, it's about a 65% chance that the kidney would still be in place a year later compared to more than an 80% chance if it's a higher concentration. And there are lots of examples of other transplants with similar sort of statistics. Here's an example from oncology of a relationship between drug levels and response. So this was a study from years ago using a drug, teniposide. Teniposide is almost an anagram of etoposide, very similar drug. VM26 is the abbreviation, VP16 is the abbreviation for etoposide. A study from some time ago showed that if you infused teniposide over a period of time into patients with solid tumours at different concentrations, you found that you got different levels, but you didn't get a necessarily consistent increase with time. You got a lot of variability at each dose level. But the study I'm reporting here, which is John Rodman's, shows that within each subgroup there'd be patients who had high concentrations and low concentrations. The ones who had the higher concentrations were the ones who had responses. If your steady state concentration was low, you were likely to have no response, and this was consistent despite having quite a wide range of absolute dosing in these patients. And they tended to choose a steady state concentration of about 12 micrograms per mil, defining whether or not you would or wouldn't respond. An example which is more relevant now is L-asparaginase. Asparaginase is very widely used. It's used in all patients with leukemia or lymphoblastic leukemia. Initially it was found in guinea pig serum. It's also synthesized by two different bacteria, E. coli and Erwinia, and its action is to cause depletion of the systemic asparagine pool. Now, asparagine is not an essential amino acid, but strangely, leukemic blasts often do not have the rescue mechanism to resynthesize asparagine if it's depleted, whereas other cells in the body do. So asparaginase has been used widely in ALL, also in AML, and also in non-Hodgkin's lymphoma. Here's a sort of diagram of what I'm talking about. You've got the extracellular space here, and your asparaginase, which has been fused, and this is your intracellular space. And so you've got asparagine, which is broken down by L-asparaginase to aspartate, and that floats around in the body, and some of it is absorbed into the cells, where it combines with glutamine, and by the enzyme asparagine synthetase gives you asparagine and glutamate. So you resynthesize depleted asparagine. Of course, once you've got an intracellular supply of asparagine, some of it will diffuse outwards where it's broken down by asparaginase. So your cells which have asparagine synthetase survive, but your leukemic blasts, which may not express asparagine synthetase, will become functionally deficient in asparagine, unable to produce proteins, and that is a fairly powerful trigger to cell death. If you look at drug levels of asparaginase after it's been given, this is after an intramuscular injection. It's a bit, it's a similar shape to the oral curve. You find that you get a slow, rapid rise, and then a redistribution phase, and then a nice smooth exponential decay. Now, some years ago, there was a chap called Joachim Buss in Münster who was looking at asparaginase therapy in E. coli. The story was that in Germany at the time they changed their supplier of asparaginase from one called Krasnitin, which is made by Bayer, I think, to a different one made by Medac. And they were different E. coli strains, but they were still E. coli asparaginase, and they were quoted as having the same activity, but what they found was that they suddenly had a high incidence of hemorrhagic and thromboembolic complications, which are recognized side effects of asparaginase. They had the sense to start measuring levels of asparaginase, and they found that trough activities after Krasnitin, after the old drug, were relatively low, significantly higher with the Medac product. You still had depletion of asparagine, but this presumably was going to be much more profound and go on for longer with the new product. And the explanation that they came to, the conclusion they came to, was that these patients were being overdosed. They also, incidentally, looked at patients who reacted to E. coli. The normal response, if someone reacts to an E. coli asparaginase, is to give them the Erwinia product. And what they found was that in those patients, the E. coli give significant depletion of asparaginase with high, of asparagine with high asparaginase levels. But if you looked at what happened with the Erwinia, they found that asparaginase activity was extremely low. So low, in fact, that you may as well not be giving the drug at all. If you look at levels of asparagine in the serum of patients who've been receiving these various drugs, what you found was that 60% of patients with Krasnitin, the old preparation, had complete asparagine depletion. With the Medac product, it was more than 90% of patients, and with the Erwinia product, it was only 26%. So there was a significant concern that your toxicity was being produced by the new version, and also that Erwinia was perhaps not doing the job it was supposed to do. One of the things that came from that was a study in childhood leukemia, which compared. It was a direct randomized study between E. coli and Erwinia in the EORTC 58881 study. And they looked at event-free survival in these populations, and yes, they found a highly significant difference in survival between two preparations of E. coli, of asparaginase, either E. coli or Erwinia. Now, if in the structure of a clinical trial where one drug can give you a 10% difference in overall survival, it's kind of suggests that you need to pay attention to things like pharmacokinetics, and this is the best documented example that I can think of at the moment. Then you think of the other 8 drugs that are used in leukemia, and you think, well, what about if we optimize those as well? They also did this in childhood NHL, slightly different protocol, and a fewer patients, and they also found a very significant difference. I mean, the E. coli preparation gave 100% survival, and the Erwinia gave only a 74% survival. The significance level is less, but the potential clinical benefit is very significant. So, asparagine pharmacokinetics are potentially quite important. I've changed the curve that I showed. These are the same data, but they're on a logarithmic scale. And on a logarithmic scale, an exponential decay is a straight line. So you have a redistribution phase followed by a straight line, which means mono-exponential decay. And if you do lots of different studies of different patients, this is the sort of data that we found. This is studies from UK patients in Bristol. This white line represents the concentration of asparaginase, which is said to be able to produce asparagine depletion. You can see that after 48 hours, quite a number of patients didn't have sufficient to cause depletion, and after 72 hours, so after 3 days, the majority of patients wouldn't have depletion of asparagine, which means that essentially the drug wasn't working. So you can draw your own conclusions from that. It's the variability of the pharmacokinetics which is the important parameter here. Methotrexate. Methotrexate is central to leukemia management. It has many uses and it's administered in many different ways. It has 3 main ways of acting. Methotrexate and also these things called methotrexate polyglutamates inhibit dihydrofolate reductase, and that's the most common and well-known pathway. But it also inhibits de novo purine synthesis by inhibiting a number of purine synthetic enzymes, and polyglutamates in particular inhibit thymidylate synthase, causing pyrimidine production to be limited. So whilst you initially only get purine blockade, you can also get more profound blockade, especially when you get lots of polyglutamates being formed. Toxicities of methotrexate include things like causing neurotoxicity, causing fits or encephalopathy. Here's a study done a long time ago, 1977. Patients received different doses of methotrexate as a 48-hour continuous infusion, and they found a wide range of concentrations at the end of that infusion. You can see that the concentration here goes from 10 to the minus 9 to 10 to the minus 6 or more. And then these red dots indicate those patients who had neurotoxicity, so patients who had significant toxicity from the methotrexate. They're the ones who had the highest overall exposure. They weren't necessarily the ones who had the highest concentration. In fact, the patients who had the highest total doses of drug didn't have any significant toxicity to speak of. Also in 1977, I'm going back a long way because these are really very fundamental papers, but they're also these things have been known for donkey's years. Archie Blyer did a very impressive paper. He took 47 patients, and they were aged between 3 years and 39 years, so really very adult. And he gave them intrathecal doses of chemotherapy of methotrexate to 12 milligrams per meter squared. Okay, so this was dosing according to surface area. And what he found was that there was a 100-fold variation in the concentration of methotrexate in the CSF. So rather more than you'd expect. He found 6 out of 10 patients over the age of 20 had significant neurotoxicity, and that was related to having very high CSF concentrations. And he also found that the patients who had the lowest concentrations failed to achieve CNS remission. And this graph sort of summarizes why these things would be found. If you look at the way in which your CNS volume rises with age, you see that there's a very rapid expansion in the early years. So that, for example, at the age of 2, your body surface area is only about 30% of your total of your adult value, whereas your CNS volume is about 80%. So that explains why you need to pay attention to age rather than body size in determining how much drug to give, because your CNS volume determines the concentration of drug it's being distributed in.